This conference will now be recorded.
So today we are going to talk about early pregnancy complications, NICE clinical guideline number 126. And this guideline was published on April 17, 2019. One of the most important guidelines because it addresses many issues here. So you should have very clear concept so that you should be able to answer all questions on your exam on the early pregnancy complications, namely ectopic pregnancy and miscarriage. That's what we see very frequently. Don't undermine the value of sport and information giving. Treat with dignity and respect all the patients all the time. And the women, they will react to complications or the loss of pregnancy in different ways. They can be very angry with you, they can be very emotional, they can be crying. Some of them, they can have like this suicidal thoughts, and they may think that they have failed themselves and their families at it. But it's your job to reassure them. Okay, tell them that this is part of life. So many things can go wrong. We can diagnose some of them right now, and we cannot diagnose many of them right now. So it is better to offer care in a dedicated early pregnancy care unit. And if the patient comes to you, she merits admission, of course, you are going to admit her. If she doesn't need admission, then you can help her, and you can give her a 24-hour contact number and tell them that where they should go. If they are asymptomatic, tell them that they can go home now. It's pretty safe. They will not face any problems. But if they have any concerns, they should come back to the hospital. So the important questions they will want you to address, these are like once the miscarriage has occurred, you have done the treatment, and then they will like to ask you when they can start having like they can start having sexual activity, when they can resume it, because they are looking forward to have another pregnancy, and they will do everything to make that successful. So you need to address the emotional issues in detail. And then if she is coming to you, she has some symptoms and she has some problems. So now you need to see that which treatment plan is going to work for her. So you know that it can be done in several ways, at several places, and whatever is the setting, the patient is going to ask you many questions. What are those questions? What to expect during recovery? When to expect recovery? Okay. What will be the impact of miscarriage on the future fertility? And how to get some support. So, you know, the patients are really stressed out. So they will ask definitely for the support and the counseling services. So give them the leaflet. Always give something to them. Give them patient information leaflet. Tell them about the sport groups and tell them about the sport organizations also. Okay. That's how you can help your patient at multiple points in the same sitting. And then it is not only one thing that you have just given them the services, you have given the information, and that's it. No, things don't work like this, okay? Ensure that they have registered this information. How you will know that? Ask them, can you please just tell me that what I have just told you? Okay. So can you explain to me that what I have just told you? No. So ensure that they have given sufficient information and you have enough time to discuss all of these things, and then still tell them that if they have any problem, they should call you back, or they should call the one who is in charge. Follow up is very important. Ensure that in such cases you don't you don't lose this patient to follow up. It will be disastrous, right? Because your patient can develop so many complications at any time. Then another question they love to ask you is that where the patient should receive service. So if the patient is having some complications in the past and now she has come back to you, then you should tell her about the early pregnancy assessment services, and they can go there, especially if they have some bad history. Why? Because these people, they have been specially trained, and they are running dedicated service, and they can pick up many things very easily, okay, because of their training, and they will have the functional protocols and the algorithms in place, and they can help their patients well. These early pregnancy assessment units, they are fully equipped, and they have the labs, and they can do the serum beta hCG. They can also carry out the transvaginal ultrasound, because these people, they have been trained to do screening in such scenarios, in such clinical situations. So their skill is much more better than the general OB/GYN people like that. So and then mostly how the patient will come to you. They will come to you with pain and bleeding, and they will come to you with pain or bleeding. So anything can be there. And then electronic, now you should know that the non-technical skills are gaining more and more importance, right? So you should know how things work, how the patient will go through the system, what information should be provided to her for the good care, like that, okay? So that she will not miss any appointments, and she will be fine, and she should know that what to anticipate in the course of the illness, and when she will expect some improvement. So what are the general symptoms of ectopic pregnancy at the time of presentation? Yes, in the previous video, we talked about the ectopic pregnancy detail, but quickly let's go over what the NICE has to say. So first of all, it depends that how the patient has reached the hospital. If she has managed to come herself, so she is stable. If she has been brought by someone, so maybe she was in a bad condition, she may be hemodynamically unstable, and then you can have significant concerns about pain and bleeding. So this patient should directly go to the A&E department. If she is stable, she can stay with you in the office. Then you should remember, sometimes the patients, they can have very atypical presentations. Symptoms can be very, very confusing. Like they have pain, then they can have pain due to a number of conditions, right? So, but in this case, your patient will be pregnant, pregnancy would have been confirmed. Okay. So ectopic in particular, it can present with many different symptoms. If I talk about the common symptoms, these are abdominal or pelvic pain, amenorrhea or missed period, vaginal bleeding with or without clots, and the other symptoms which have been reported by many pregnant women, these include breast tenderness, gastrointestinal symptoms, dizziness, fainting or syncope, and syncope like sudden loss of consciousness for short periods of time. She can have shoulder tip pain. Why she will have shoulder tip pain? Because maybe she has some bleeding in the peritoneal cavity, and now the blood is irritating diaphragm. And diaphragm and the common phrenic nerve, they have the same nerve supply, C234. So the pain is referred to the tip of the shoulder, and more pain on the right side of the shoulder, in the right shoulder. So then they can have urinary symptoms like urgency, burning. They could have passed some tissue, and then they can feel some rectal pressure, because anyhow the uterus was gravid, even if the pregnancy is ectopic, but the uterus will be a bit large. Why? Because of the endometrial changes. And then you should know that the ectopic can present with many other symptoms also. The signs can also be different. The symptoms are different, and the signs. What are the symptoms which the patient experienced and she shared with us? What are the signs that we are going to see clinically? So the common signs of ectopic pregnancy include pelvic tenderness, adnexal tenderness, abdominal tenderness, and the other reported signs are cervical motion tenderness, rebound tenderness or peritoneal signs, pallor, abdominal distension, enlarged uterus, tachycardia, like the heartbeat of the mother is more than 100 beats per minute, or she can have hypotension, like the BP will be less than 100 by 60. She can be shocked, or she could be collapsed. They can also have orthostatic hypotension. What is orthostatic hypotension? That when she is getting up, from the sitting or the lying position, she is getting up, standing, and there is a drop in the systolic BP and by 20 millimeter of mercury, and that drop in the diastolic BP by 10 millimeter of mercury, then you will say that the patient has orthostatic hypotension. So during the clinical assessment, you should know that if she's coming very early to you, like maybe she's in the even before missing her period, so the first test you are going to run would be pregnancy test. There is a first test that you should be doing in the women of the reproductive age group, even if they are coming with UTI, if unless because the symptoms of ectopic pregnancy mostly they resemble the symptoms in the GIT or the urinary tract. So that is one thing, and something which will be like which will distinct them from the GIT pathology or the urinary tract infection. These are pelvic pain, abdominal pain, pelvic tenderness, or cervical motion tenderness. So you should exclude the possibility of ectopic pregnancy even in the absence of risk factors. It is not necessary that only those women who have certain risk factors, they will develop ectopic pregnancy. Completely is good general history, no history of PID, no history of other infections, nothing, no history of tubal damage, still your patient can end up having ectopic pregnancy due to certain factors. So this patient should be referred to the early pregnancy assessment unit. If she's stable, they will keep her, but if she has pain or bleeding, then they are going to keep them. So what are the signs of the complications? Obviously, if your patient has a bleed, she's bleeding, she has pain, or she has a gestational period of more than 6 weeks, okay, or she has a pregnancy of uncertain gestation. Here, I didn't say that unknown location, uncertain gestation. We don't know that this is intrauterine, extrauterine, or where it is. And the urgency of this referral will depend upon the clinical situation. So if the pregnancy duration is less than 6 weeks, then you don't have to do much. If the woman is stable, just offer her expectant management. So then tell her that she should come back. She should return if bleeding continues or pain develops. And then at this follow-up visit, what will you like to do? You would like to repeat a urine pregnancy test after 7 to 10 days, and then you will tell the patient that she should return. She can do a home pregnancy test, and if it turns out to be positive, then she should come to the early pregnancy unit. If at this gestation the patient repeated the test, let's say after 3 weeks, after 7 to 10 days, and it is negative, so the patient can stay home like that. Okay? That is one thing. Unless and she needs contraception, she will go to the GP. But if the woman has symptoms which are worsening, like the pain is increasing, bleeding is increasing, she has passed some tissue, then we need to refer her to the early pregnancy assessment unit. So basically, if they ask you on which basis you will diagnose, you will manage her, where you will refer this patient, then you will say that depends upon her clinical situation. If she needs to be admitted, I will refer her to the A&D. If she needs like regular care, I will send her to the regular early pregnancy assessment unit. These are the things. Stable, she can come back to the clinic for the follow-up. So how do we diagnose viable intrauterine pregnancy, and how do we diagnose tubal ectopic pregnancy? So the women who come to the early pregnancy assessment unit and they are coming at the odd hours, then we can do a TVS, transvaginal scan. That is the first investigation of choice. And we will say that what is the location of the pregnancy? Is there any fetal pole? And if a fetal pole is there, are there any heartbeats? So if the women, they have a larger uterus, then we will offer them abdominal ultrasound, because what you would like to see, you would like to see that is this only the pregnancy, and what is the duration of pregnancy is more than like 6 weeks or more, or she has some other abnormalities. What other abnormalities can be there? Maybe the fibroid is there, or fibroid can be there. What else can be there? Maybe there it was case of like some ovarian cyst, right? So think about the alternate pathologies also. If the woman doesn't like to have the TBS, then you should offer her transabdominal scanning, but that will be the second line investigation. First line investigation is only TBS, and the second line is to do the abdominal ultrasound. So when we are using the ultrasound for the ultrasound scan for the diagnosis of viable intrauterine pregnancy, you should remember that the diagnosis of miscarriage cannot be made with 100% confidence on the transabdominal ultrasound. There is a small chance that the diagnosis can be incorrect, especially if the patient is coming to you at very early stage in the pregnancy. So when we are doing the scan, ultrasound scan to determine the viability of an intrauterine pregnancy, first of all, you should look at identifying the heartbeat, fetal heartbeat. Is it positive? Then what is the rate? If there is no visible heartbeat, but there is a visible fetal pole, then you should measure the CR length, which is crown rump length. And if the fetal pole is not visible, then obviously you cannot take the crown rump length. What will you do now? Now you need to take the diameter of the gestational sac. If the crown rump length CRL is less than 7 millimeter on TBS scan and there is no fetal heartbeat, so you can't diagnose that this patient is having miscarriage right now. Let her go back and return in 7 weeks time. She can return in 7 to 10 weeks time. At that time, we will repeat the scan and now we can diagnose if this is an ongoing pregnancy or this is a case of miscarriage, or if the CRL is 7 millimeter or more and you are doing the TBS, no visible heartbeat, then what you will do? You will say that in the previous example also the CRL was only 7 and it is 7 now. So what you will do? CRL is 7 millimeter or more than 7 millimeter. So this is the high time when we should be able to find a heartbeat. If it is not here, so take what you will do. You will take record the CRL again and make a note of that, and then you should repeat scan a minimum of 14 days if you have to, for the diagnosis. This is when you are offering her abdominal scan. So in the answering the single best answer questions, you should be very careful that what type of scan they did. If they did the TBS, then you will call this patient back after 7 days. And if you did the abdominal scan, then call this patient back after 14 days. These are two different recommendations, okay? Don't confuse them. Now, if you couldn't take this CRL, and then you will take the general gestational sac diameter. If it is less than 25 millimeter with a TBS and there is no visible fetal pole, then you should do a second scan a minimum of 7 days after the first before making any diagnosis. And then further scans may be needed if the situation demands. And before making any diagnosis, because sometimes you really cannot diagnose. If the mean sac diameter is 25 millimeter or more using the TBS and now there is no visible fetal pole, then you will take a second opinion on the viability of the pregnancy, or you can perform a second scan a minimum of 7 days after the first before making the diagnosis. So 25 millimeter, less than 25 millimeter, the gestation sac, follow-up scan. It is when the gestation sac is 25 millimeter or bigger than this one, then you will take a second opinion. And if you have any concerns, then you are going to repeat the second scan 7 days after the first first scan. And after that, you will make the diagnosis. Never diagnose ectopic or miscarriage in the first presentation, okay, at the time of presentation. Just wait, rescan, re-evaluate, and then tell your patient, because you have to be sure. You have to be sure of your diagnosis. Okay, so then you should remember that even if the sac diameter is larger, and you have done the transabdominal scan, right? And the sac diameter is 25 or larger and no visible fetal pore. So what are you going to do? You will record the size of the mean gestational sac diameter. How you will do that? You will take the diameter, you will take three sizes, okay? Up and down, right and left, and then in the oblique section, and you will get the diameter. Even if you will take this two dimensions, you can make the diagnosis. You can measure the sac volume diameter, okay? And then if you are doing the abdominal scan, so you should repeat it after 14 days. And don't choose gestational age from the last menstrual period alone to determine whether the fetal heart rate should be visible or not. Why? Because everyone is not having a 28-day cycle. The length of the cycle can be anywhere between 21 to 35 days. Okay, and then you should say that their last menstrual period, it may not be accurate at the accurate representation of the gestational age, because there can be variability in the menstrual cycle. Even the cycles can vary from one cycle to another one. And that's why it is important to follow up. They should wait for the follow-up scan, and you should tell them that it will not affect their care, their condition, so they can wait. Just provide, whenever you are giving the follow-up appointment, always give a 24-hour contact number, and tell them that who will be available on the line, and then they can they can they can they can contact that number if they develop any problem, and if they develop serious symptoms, then they can return to the hospital also like that. So if you couldn't do the previous scan and the patient has come to you, then still you should say that if nothing is seen at all at the initial presentation, and then she will return and you will do the ultrasound again and nothing is seen, so then you can see, but the serum beta ICG is positive, so then you can make the diagnosis of pregnancy of unknown location. So the ectopic pregnancy, we talked about it yesterday. We talked about all the parameters, so I think I will not go back to that one. So better to talk about the pregnancy of unknown location. If you were not in the class, then please go to the channel and listen to the video on diagnosis and management of ectopic pregnancy, guideline number, green top guideline number 21. Okay. So if you still have any question, please feel free to drop an email. So if the women have pregnancy of unknown location, then we will have to rely on the HCG, beta HCG, or the human chorionic gonadotrophin levels measurements. So if there is a pregnancy of the unknown location, beta HCG is positive, then after that, you don't have to repeat the serum beta HCG to determine the location of the pregnancy, because it will only tell you that the pregnancy is there, but where it is, it will not tell. Okay, that is one thing. And then every time the woman comes to you, then you need to pay attention to the clinical condition. Don't say that what happened in the last visit. See how she's presenting now, like that, okay? And do ultrasound, and then you can reach some conclusion. At least you should have 2 serum beta HCG measurements, and as near as possible to 48 hours apart, but not earlier, to determine the subsequent management of a pregnancy of the unknown location. And take further measurements only after reviewed by a senior healthcare professional. Then, regardless of the serum HCG levels, give women with a pregnancy of unknown location, give them written information about what to do if they experience any new or worsening symptoms, including details about how to access emergency care 24 hours a day. And tell them that if they develop new symptoms or the pain increases significantly or the bleeding increases, they should come to the hospital immediately. And for the women, like you did the initial scan, after 48, you did the baseline serum beta ICG. Then after 48 hours, you called her back for the repeat beta ICG, and the rise in the serum HCG level is greater than 63%, then you will tell her that it is likely to have a developing intrauterine pregnancy, although we cannot exclude the possibility of ectopic pregnancy, because ectopic you will exclude only if you have a significant rise in the beta ICG and then you are repeating ultrasound. So to see something, gestation growing pregnancy on the transabdominal scan, the serum beta ICG level should be at least 3,500 and preferably it should be 6,000. Similarly, for the TVS, better if the levels are around 3,000, but very hard to see anything at 1,500 or 2,000 international units like that. So, but keep these 1,500 and 3,000 units. This is the minimum level required to make the diagnosis on the scanning. Okay. Then after her, she has returned, and you have done, there is a beta ICG rise of 63%. Repeat the scan. If the things are fine, she's stable, let her go back and tell her that she should come back between 7 to 14 days later. And at this stage, you can repeat the ultrasound because we anticipate that at this stage, we should be able to visualize gestational sac. So, and you can do the ultrasound earlier than 7 or 14 days, 7 to 14 days, if the beta ICG at the initial presentation was equal to or more than 1,500 international units. So read the question very carefully. What was her condition? How it is evolving? How stable is your patient? And then think about it. And for the women whose beta HCG is dropping at between the first test, that was at 0 hours, and the second beta HCG testing at 48 hours, and the beta HCG has dropped greater than 50%, then you need to tell them that it is not confirmed, but the pregnancy is unlikely to continue because the serum beta ICG levels are dropping like that. Okay. Then tell her that she should take a urine pregnancy test 14 days after the second serum beta ICG test and explain to her that if this home pregnancy test it turns out to be negative, or maybe she can do in the GP practice that the repeat test is negative, then it means that you have a miscarriage and just relax and you will get your periods next month. That is one. So no further action is necessary. If the test is positive, she should return to the early pregnancy assessment service for clinical review within 24 hours. Test is positive, so we need to see that this is a pregnancy of known location or unknown location. And for a woman with a decrease in the serum beta HCG level less than 50% or increase which is less than 63%, we should refer them for the clinical review to the early pregnancy assessment service within 24 hours. This information is very important because they ask you very simple questions in the single best answers that this is a scenario. Patient serum beta ICG level is so and so. So where she should go for the care. So the answer is not early pregnancy unit, assessment unit for everyone. There are certain criteria. Follow them. Okay. So if you are suspecting that the woman has pregnancy of unknown location, don't have to do the serum progesterone levels. Why? Because they will not give you any information. So don't offer them anything. Now that this woman has come to you and she has, so that's all about the pregnancy of unknown location. Patient can come to you with another complication. Remember, we are talking about early pregnancy complications. These two complications are more common, but patient can present to you with other complications also. Other complications can be management of threatened miscarriage. What is a threatened miscarriage by definition? That the woman had a pregnancy which has been seen or on ultrasound, it has been confirmed, and she presents with vaginal bleeding, and there is a with, but she has no history of previous miscarriage. Like she came to us, she had a bleed, the pregnancy was fine, but the miscarriage has not taken place. Okay, there is a pregnancy inside uterus and the woman is experiencing pain or bleeding like that, but the contents of the pregnancy are still inside her uterus. So then we will say that this is a threatened miscarriage and the os of the os will be closed. Os of the cervix will be closed. So if you have a woman with confirmed intrauterine pregnancy and she had fetal heartbeat and she presents with vaginal bleeding and no history of miscarriage, then you will tell her that if her bleeding gets burst or bleeding persists after 14 days and beyond 14 days, she should return for further assessment. And if the bleeding stops, then she doesn't have to come to the early pregnancy unit, then she can simply continue her routine antenatal care. Nothing is wrong with her, things are fine, but she has some bleed, she had some problem. Most likely it maybe occurred around the time of implantation. Okay, and also important to ask that what is the color of the bleeding? Is it brown or is it red? If it is brown, then it is obviously old blood because it has hemolyzed. And if it is red, bright red, then it means that this is fresh bleeding. And don't forget to give her folic acid at this time. So you are going to give her folic acid if she is not taking from the start, but now she has bleeding. So you are going to give her vaginal micronized progesterone. Give her in a dose of 400 milligram twice daily. If they have intrauterine pregnancy, which was confirmed by a scan, if it has been documented and she had this bleeding, then you are going to give her progesterone sport. 400 mg micronized progesterone through the vaginal route. And if a fetal heartbeat is confirmed, then you can continue progesterone in such cases until 16 completed weeks of pregnancy. That is one thing, okay? So this should be used. So in the threatened miscarriage, you will give progesterone, okay, 400 mg BID. Now, going back to the treatment of the miscarriage, you can offer all different treatments. What are those all different treatments? Always give full option to the patient, full option of selecting that treatment, okay? Counsel her well and then include her in the decision making. Like we talked about the ectopic pregnancy, in the management of the miscarriage also, we can tell her that she can have expectant management, or she can have a medical treatment, or she can go for a surgical management. Expectant management, it can be used for 7 to 14 days as the first line management for the women with a confirmed diagnosis of miscarriage. And other management options, they should also be checked because the management is going to vary as the situation, condition of the woman will change. If the woman is at increased risk of hemorrhage, for example, she is having miscarriage towards the later half of the first trimester, that is at 11 to 13 weeks, then you should know that this patient can have profuse bleeding like that. Okay. So then or if she has like history of previous adverse outcomes, or she had traumatic experience with the pregnancy. For example, she had stillbirth, miscarriage, or she has experienced antepartum hemorrhage, or she is at increased risk from the effects of hemorrhage. For example, she has some coagulopathy, or she belongs to some religious group or something where she doesn't believe that they should be receiving the blood or the blood products. She is refusing them, or there is any evidence of infection. So in these cases, you will think that should I give her expectant management or I should not give it to her. Okay, so you need to see that what is the extent of these problems, and then you will give your order accordingly. If the diagnosis of miscarriage has been confirmed and the woman is not fit to go to receive expectant management, like all of these four scenarios I have told you, like she's at increased risk of hemorrhage, she has previous bad experience, and she's having some coagulopathies, or there is evidence of infection. In such cases, you can explore her ideas if she will accept the medical treatment of the miscarriage. If it is okay with her, just tell her about the side effects and the benefits, everything, okay? And whatever management you are giving, you need to give her oral information, and which should be backed by the written information. And if the resolution of the bleeding and the pain occurs, then you should tell her that it means that she has completed miscarriage. She has completed miscarriage, and that's why she has no bleed. But if it continues, then it means that things are bad. So if the bleeding and the pain they stop, it means that miscarriage has occurred during 7 to 14 days of expectant management. So tell her to take a urine pregnancy test, and this test we are going to provide her. If this is negative, then it is fine. She can just wait for the next periods, and she can start using the contraception. But if it is positive, she should return to us like that. Okay, that is very important. So if the test turns out to be positive, tell her to come back to the hospital. So that is one thing. And it may also mean that the miscarriage is incomplete, provided it was not like a missed miscarriage like that. That is one thing. Okay. So expectant management usually is not continued beyond 14 days. And after that, you will have to see that, review her, that is she still fit to continue receiving this expectant management, or we should escalate the level and give her the medical management, some therapy. So for some patients, you can start the medical management right from the start. So then you should remember which drugs we can give and which drugs should be avoided. Mifepristone, we don't have to give. This is like the progesterone receptor modulator. So we don't give that anymore now. In such scenarios can be given if the consultant wants, but the guideline says that you don't have to give it. So don't offer mifepristone as a treatment for the missed or incomplete miscarriage. You can offer vaginal misoprostol for the medical treatment of missed or incomplete miscarriage, and oral administration is also acceptable. And if the woman has missed miscarriage, then you are going to give a single dose of 800 micrograms of misoprostol. Sometimes the exam questions are very super simple. They will ask you, this is the condition of the woman, she has a missed miscarriage, so how much progesterone you will like to give her? Your answer is 800 microgram. And for women who have incomplete miscarriage, you will use a single dose of 600 micrograms of misoprostol. And sometimes some units, I know that some units, even some trusts, even in NHS, they give them 800 micrograms, both are acceptable. So we need to offer all women who are receiving medical treatment of miscarriage, we have to give them antiemetics. You can give them promethazine, you can give them cyclozine, metoclopramide, and you have to give them good pain control, good analgesia, and antiemetics. These are essential. Don't forget them. Okay, they usually give you a combination of the drugs that which one is going to be a good bet for, safe bet for your patient. Offer all women receiving medical therapy what? Pain relief and antiemetics. And the women, they should again take a pregnancy test 3 weeks later after medical management of the miscarriage. And but if they develop serious symptoms like the pain is increasing, bleeding is too heavy, then they should return to the hospital for the admission and further management. If they have a positive test after 3 weeks, then you need to tell them that they should return to the OB/GYN care. And now what you would like to exclude here? Any one of you? You can write down in the chat box. Yeah. So you can, you need to exclude the molar pregnancy and ectopic pregnancy. Now the third treatment option, that is surgical management. So where it is clinically appropriate, you should offer women undergoing miscarriage a choice of manual vacuum aspiration under the local anesthetic in the outpatient setting. That is very safe, but it has certain indications like the size of the products of conceptions. It should not be more than 5 centimeter. Woman should not have any contraindications. She should not have any cervical stenosis. Okay, and mostly if she's not primary gravida, then it is even better. Okay, there should be no fetal heartbeat. Okay, and there should be no infection, and the pregnancy should have been seen before on ultrasound. Then you can go for manual vacuum aspiration. Good counseling, local anesthetic agent. This instrument is going to help you. So manual vacuum aspiration in the outpatient setting. But if your patient declines it, or she is a primary gravida, right, and she has bleeding or she is hemodynamically unstable, then you need to do the surgical management in the theater under general anesthesia. Once the patient is inside OR for with bleeding, you will give general anesthesia. And then you need to give them information in the form of patient information leaflet before the procedure. Then tell them that what they should expect during hospital stay, during procedure, and after the procedure. Again, the same questions. What is the cause? What has caused this miscarriage? Is it my mistake? Did I do something wrong? So what happened? Is it my fault? When can I resume sexual activity? So when can I try to conceive again? And what to expect? What will be the fertility outcome? Okay, so you are going to answer all of these things, and you will say that it is quite possible to have a normal pregnancy. There will be no effect of this miscarriage on the income on the next pregnancy. That is one thing. Okay. Then another favorite question of the examiners: are you going to give anti-D or a rhesus prophylaxis? So the NICE guideline says that you're going to offer anti-D rhesus prophylaxis at doses of 250 international units or 50 microgram to all Rh negative women who have a surgical procedure to manage an ectopic pregnancy or miscarriage. And then you should not be offering this anti-D prophylaxis to the women who have received only the medical treatment of foreign ectopic pregnancy or miscarriage, or who have a threatened miscarriage or have a complete this miscarriage, or who have a pregnancy of unknown location. And then you don't have to do Kleihard test for qualifying feto-maternal hemorrhage. No role of this Kleihard-Betke test in such scenarios, so don't offer it to the patients. So now there are certain differences in the recommendations on anti-D prophylaxis among RCOG and yes, RCOG and nice guidelines. Okay, so you need to see that all of these things, they are applicable to different patients like that. Okay, you would like to tell me that when you will not be giving this NTD according to the Green Top guideline? If the woman has a good level of antibodies, she didn't experience any significant pain because there were no contractions, and she is not planning to have other babies, or she's planning to undergo hysterectomy. If she is reliable, then you will not give. But in all other conditions, you will give it to her like that. Okay, that is one thing which is very important. Similarly, the RCOG also says, yeah, ectopic is treated with methotrexate, don't give it to her. She doesn't need it like that. Okay, that is one thing. So don't give it to her because she doesn't need it. These are important questions. Okay, but if she experiences any pain, something, then of course you need to give it to her. So these are the important things, important issues. They are always asking you questions about these things. So you should know about them, know about the different complications, and know about their management like that. Okay. So now again, what are the questions they are asking you? They are asking you like, yeah, what are the most common causes of bleeding in the first trimester? Of course, miscarriage, ectopic pregnancy. Like the 30% of the cases of bleeding are because of miscarriage, 10 to 15% can be ectopic pregnancies, and the molar pregnancy just 0.2%. Okay. So then, what is the most important reason for maternal mortality in the first trimester of the pregnancy? Then your answer is not miscarriage, your answer is going to be ectopic pregnancy. 5% mortality rate is because of the ectopic pregnancy. And what complications of ectopic? Like ectopic by itself is not going to kill anyone. If it ruptures, there is bleeding, there is hemorrhagic shock, or the patient develops disseminated intravascular coagulation. So then the patient can experience very adverse consequences of having miscarriage like that. Okay, that is one thing. So spontaneous miscarriage, when it can occur. So the pregnancy losses which are occurring prior to 20th week of gestation, or before 24th week of gestation, or the fetus is weighing less than 500 grams, all of these outcomes are defined as the miscarriage like that. That is one thing. Okay. And you should remember that the risk of miscarriage will increase up to the 15th week, and after that the risk is going to decline. What is the classic clinical presentation of the miscarriage? Of obviously bleeding, pelvic pain, abdominal pain. These are the things. Okay. And then the amount of bleeding, it can be scanty or heavy. It is not going to tell you that what type of miscarriage the patient is having like that. Okay. Then what are the risk factors for spontaneous miscarriage? Your answer is, they will give you one of these options. Okay, advanced maternal age, that is the age more than 40. Having history of previous spontaneous miscarriage, smoking, alcohol, cocaine, NSAIDs, not acetaminophen, others. Then it is also important to note that even the smoking, 1 cigarette per day, it can also increase the risk of sudden unexplained infant death. Other important factors are high BMI, okay, or very low BMI, BMI less than 17, fever, trauma, congenital anomalies, then uterine structural abnormalities such as like uterine septum, then the infections. Which infections? Listeria, toxoplasmosis, parvovirus P19, rubella, herpes simplex, CMV, and the Zika virus. Maternal systemic disorders like the hypertension, diabetes mellitus, thyroid disease, celiac disease, systemic lupus erythematosus, antiphospholipid syndrome, all of them, they increase the risk of miscarriage. If she is taking more than 4 cups of coffee a day, this is also a risk factor for miscarriage. And the chances of miscarriage are higher in lower socio-economic status, in the women with the agricultural work or the manual work, lower income and lower educational levels. That is one thing. Okay. So then another question can be, what is the most common cause of miscarriage in the first trimester? Your answer is going to be fetal chromosomal anomalies. Okay, which is the most common chromosomal abnormality seen in the um, aborted fetuses. In the aborta, you will say trisomy 16. This is so bad that we don't get to see anyone living with chromosome 16, trisomy 16, because all of them they will be aborted in the early pregnancy. Okay. Okay, so the most common cause of spontaneous miscarriage in the second trimester, obviously cervical weakness. So what other conditions can present as spontaneous miscarriage? That is the differential diagnosis. Your answer is physiological, like secondary to implantation. Your patient can experience pain and bleeding. Then ectopic pregnancy, gestational trophoblastic disease, cervical, vaginal or uterine pathology, neoplasm, trauma. There can be subchorionic hematoma, there can be rectal bleeding, there can be hemorrhoids and hematuria. Classifications, different types, you should know about them, that there can be threatened miscarriage, missed and embryonic or the empty sac, inevitable miscarriage, then there can be incomplete miscarriage. Then there can be complete miscarriage and then septic miscarriage. By definition, what is a threatened miscarriage? Vaginal bleeding that occurs, but in a case where the cervical os is closed and fetal cardiac activity is positive and the intrauterine pregnancy has been documented. So if your patient has threatened miscarriage, do you think she is going to experience any bad effects in the later part of the pregnancy? The answer is yes. What are the adverse effects? Obviously, there can be IUGR, and then there can be miscarriage, there can be preterm birth, and premature pre-labor rupture of the membranes. All of these things are important to remember. That is one thing. Okay. So the treatments, like we are going to follow the NICE guidelines that I have told you. And what else I should be telling you? So the treatment of the DIC, septic miscarriage, is also very important. So we have to manage that carefully. First, treat with antibiotics. And if the patient is younger than 25, then you need to screen them for the infections also at the same time. So these are some of the important risk factors for miscarriage. And what happens, what are the recommendations, how we should be managing them. All of these things are very, very important, and you are going to get questions around it. So thank you very much for attending the class. And then, as I mentioned yesterday, that those who are following me, they are going to get a test on the 31st of the March. So if you will have to enter, I think, your email, and then you can take the test a single time like that. Okay, but you will get the result immediately. So thank you very much for attending, and keep working hard, because every single day you need to work on your exam. That is the only way to pass the exam. Thank you very much. Take care. Bye bye.